Okay. Next, second layer, deep to the, next one. Okay, second layer is formed by the internal oblique muscle. Okay, these are the fiber direction of internal oblique muscle. Internal oblique, and here is the transversus abdominis, third muscle layer, superficial to deep. So these two are together joining to form the conjoint tendon. Conjoint tendon forming a arch above the inguinal canal. Okay, and forming the roof of the canal like this. And deep most is the fossa transversalis. Okay, there is a gap in the fossa transversalis that is forming the deep inguinal ring, and the canal is extending from deep inguinal ring to the superficial inguinal ring. Deep inguinal ring is almost rounded, but superficial ring is triangular in outline, formed by two crura, medial crus and lateral crus, and joined by intercrural fibers. Okay, and this is the floor. Floor is formed by this inguinal ligament, and on the medial part lacunar ligament, and reflected part of the inguinal ligament. And see here the inguinal ligament is attached at the anterior superior iliac spine and pubic tubercle. Okay. Next, so these are the coverings, layers of the anterior abdominal wall from superficial to deep. You can see skin, then superficial fossa. Okay, if superficial fossa consists of two layers, outer fossa of Camper, which is a fatty layer, and inner membranous layer. Okay, and then there is muscles, external oblique muscle, then internal oblique, then fossa of both superficial and deep surfaces of the internal oblique. Then these muscles are also forming the rectus sheath. These two muscles are included within the rectus sheath, rectus abdominis and pyramidalis muscle. Then there is transversus abdominis, fossa transversalis, and extraperitoneal fatty tissue, and innermost is the peritoneum. Okay, and these are the different ligaments, peritoneal ligaments. Okay, and these structures, layers of the abdomen, yes, these layers are continuing along with the spermatic cord or round ligament of uterus into the, in male it is continuing up to the scrotum. Okay, so for the scrotum and these coverings are skin, subcutaneous tissue, that is known as dartos fossa, and one muscle layer is present here, dartos muscle. Then external oblique is forming the external spermatic fossa. Internal oblique is forming the cremasteric muscles and fossa, and fossa and transversus abdominis is forming the internal spermatic fossa. And continuation of this peritoneum, there is extension of this peritoneal sac in the fetal life, that was known as tunica vaginalis. It is also consists of two layers, parietal layer and visceral layer, and covering the testis and epididymis. Okay, and these are the covering of, all these coverings will be present of the spermatic cord, scrotum and scrotal septum, external spermatic fossa, cremaster muscle and fossa, internal spermatic fossa, vestige of the processus vaginalis. Okay, so these are the coverings of spermatic cord. Okay, next. These coverings are asked in different hernia. Okay, hernia occurs through the deep ring or through the deep ring in case of indirect inguinal hernia. Okay, and it will carry along with it all the layers of the abdomen. So you have to know first the layers of abdomen to understand the covering of the hernial sac. Okay, it is asked in your long question. And the boundaries of the inguinal canal is very, very important. It comes as a long question. Okay, and direct and indirect inguinal hernia can come as a short note. What is the cause of hernia, and some explain why questions also come from this topic. Okay, and spermatic cord, it is also a short note, contents of the spermatic cord. Okay, and very frequently asked in your viva. It can be also given in your OSPE. You have to identify the cord and write down the content. 5 marks question. Okay, so spermatic cord is very, very important. Okay, so inguinal canal, it is about 1.5 inch or 4 centimeter long in the adults, extends from the deep inguinal ring downward and medially to the superficial inguinal ring. It lies parallel to and immediately above the inguinal ligament. And in the newborn child, the deep ring lies almost directly posterior to the superficial ring. Obliquity is not present that much in newborn child. Okay. Next, now we will discuss the two rings. These two rings also can be given in your OSPI and also in short note, superficial inguinal ring and deep inguinal ring. What is the boundary, what is the structure passing through these rings are important. Okay. So, deep inguinal ring, it is an oval opening in the fossa transversalis, opening in fossa transversalis, very important for Viva MCQ, and lies about half inch or 1.3 centimeter above the inguinal ligament. Location is also asked in Viva. Above the inguinal ligament, midway between the anterior superior iliac spine and the symphysis pubis. That is mid-inguinal point. Okay, half inch above the mid-inguinal point. So, margins of the ring gives attachment to the internal spermatic fossa. Okay. Next, see, this is the canal, inguinal canal. This is external oblique aponeurosis. In female, you can see this is uterus, two tubes, fallopian tubes, ovary. At the corner of the uterus, attached this round ligament of the uterus. In female, round ligament of uterus is coming, passing through the deep inguinal ring, then traverses the inguinal canal and going to be attached to the labia majora. Okay. So, this is the content in female, and also there will be presence of ilioinguinal nerve. Three layers has been shown: external oblique, internal oblique, transversus abdominis, and this is they are forming the rectus abdominis muscle. Okay. Next we will go to superficial inguinal ring. It is triangular in shape, lies in the aponeurosis of the external oblique muscle, and it lies immediately above and medial to the pubic tubercle. Its margins give attachment to the external spermatic fossa. Next, see, this is the superficial inguinal ring, and this is spermatic cord coming out through this ring, and this nerve is the ilioinguinal nerve. Okay, and entering into the scrotum in case of male, superficial inguinal ring, and these are the arched fibers forming the roof formed by the internal oblique and transversus abdominis. Okay. Next. Okay, see, this is the canal. You have seen the femoral triangle just above. This inguinal ligament was forming the base of the triangle. Here it is forming the floor of the inguinal canal. Here is the inguinal ligament. Here is the position of deep ring, this blue outline, okay, and this green one, it is outlining the canal. Upper grooved surface of this inguinal ligament is forming the floor, and in the medial part there is lacunar ligament that is also forming the floor of the inguinal canal. And this is superficial inguinal ring, triangular in outline, formed by two crura, medial crus and lateral crus joined by the intercrural fibers, and these arched fibers are formed from the internal oblique and transversus abdominis. Okay. Next, now we will discuss the walls of the inguinal canal. So, anterior wall of the inguinal canal, it is formed along its entire length by aponeurosis of the external oblique muscle, and it is reinforced in its lateral third by the origin of internal oblique from the inguinal ligament. Okay. In the lateral third only internal oblique is present. So, and in the lateral third deep inguinal ring is also present on the posterior wall. So, this wall is strongest where it lies opposite the weakest part of posterior wall, that is deep inguinal ring. Okay. So, mainly external oblique muscle and in the lateral third internal oblique. Okay. Next, During surgery in your final year, you have to learn about the different operations of hernia. Okay, so during that also you have to remember different muscles forming the different walls. Okay, so posterior wall of inguinal canal, it is formed along its entire length by the fossa transversalis. So posterior wall by fossa transversalis, and it is reinforced in its medial third by conjoint tendon. And the what is conjoint tendon? That is also asked in Viva. The common tendon of insertion of internal oblique and transversus abdominis attached to the pubic crest and pectineal line. Okay, these two muscles, internal oblique and transversus abdominis, forming the conjoint tendon. And this wall is strongest where it lies opposite the weakest part of the anterior wall, and that is superficial inguinal ring. Okay, next. See, this part is the inguinal canal. Here it is coming out superficial inguinal ring, and here is the deep ring. See, this is external oblique aponeurosis forming the anterior wall. These two are the internal oblique and transversus abdominis forming the roof. Okay, and see, internal oblique in the lateral 1/3, internal oblique is forming the anterior wall, and in the medial 1/3, internal oblique and transversus abdominis joining to form the conjoint tendon and forming the posterior wall after forming the roof. And this is fossa transversalis. Within the fossa transversalis, the deep ring is present, and after that will be the peritoneum and the loose areolar tissue. Okay, containing the fat. See, this is the spermatic cord and its structures has been shown here, and the ilioinguinal nerve. And ilioinguinal nerve, you remember, it does not pass through this deep inguinal ring. It will pierce the roof of the canal to enter into the canal and then coming out through this superficial inguinal ring. This point is very, very important. It does not pass through the deep inguinal ring, pierces the roof, enter the canal, and comes out through this superficial inguinal ring. Okay. Next, here also you can see the layers. This is spermatic cord and its covering and the contents. See, this is external oblique muscle. Aponeurosis of the muscle is forming the anterior wall. Then internal oblique, transversus abdominis, forming the roof, then forming posterior wall. Lateral, in the lateral part, internal oblique is forming the anterior wall. But in the medial part, these two muscles joining together forming the medial part of the posterior wall. Then there is the fossa transversalis, okay, and this peritoneum and this fatty tissue. Okay. And these are the femoral vessels passing underneath this inguinal ligament. This is testis, spermatic cord is attached to testis and epididymis. Okay, next. Now, inferior wall of the inguinal canal. It is formed by the rolled under inferior edge of the aponeurosis of the external oblique muscle called the inguinal ligament, and at its medial end the lacunal ligament. These two are forming the inferior wall. Next. Now, superior wall or roof. It is formed by the arching lowest fibers of the internal oblique and transversus abdominis muscle. Next. Now, what are the functions of the inguinal canal? It allows structures of spermatic cord to pass to and from the testis to the abdomen in male and permits the passage of round ligament of uterus from uterus to the labia majora in female. Next. Okay, next is the mechanics of the inguinal canal. It is also comes as a question, part of the long question. How the, what is the mechanics of inguinal canal, or how the obliquity of the canal is maintained, how hernia is prevented, okay? How the hernia is prevented through this inguinal canal. So different mechanisms are there. You have to write all the mechanisms. Flap valve mechanism, canal is oblique canal, okay, and deep and superficial inguinal rings, they do not lie opposite to each other. During increased intra-abdominal pressure, anterior and posterior walls are approximated like a flap, and that is known as flap valve mechanism, okay. Next is guarding of the inguinal rings. Deep ring is guarded anteriorly by the internal oblique muscle, and superficial ring is guarded posteriorly by the conjoint tendon and reflected part of the inguinal ligament that prevent herniation. Okay. Next is flutter mechanism. Internal oblique muscle surrounds the canal in front, above and behind like a flexible mobile arch, forming the arch. Okay, internal oblique along with the transversus abdominis. And when it contracts, roof is pulled and approximated on the floor like a shutter. That is shutter mechanism. Okay. Next is slit valve mechanism. Contraction of the external oblique muscle approximates the two crura of the superficial ring like a slit valve, and the intercrural fibers also help in this contraction. So this is known as slit valve mechanism. Okay, different mechanisms are present. Next there is ball valve mechanism. There is contraction of cremasteric muscle which pulls the testis up, and superficial inguinal ring is plugged by the spermatic cord. That also prevents the herniation of contents of abdomen through the inguinal canal. Okay, so these are the mechanisms. Next we go to the contents. First is spermatic cord. How it is formed? Spermatic cord comes as a short note. Okay, so it is a collection of structures that pass through the inguinal canal to and from the testis. It is covered with three concentric layers of fossa derived from the layers of anterior abdominal wall. It begins at the deep inguinal ring lateral to the inferior epigastric artery and ends at the testis. This relation is important. This deep ring is always lying lateral to the inferior epigastric artery. You will see in the dissection of inguinal canal. Okay, this relation you have to note. How will you identify the deep inguinal ring? You have to find it just lateral to the inferior epigastric artery. Next. Okay, these are the coverings of the spermatic cord. Scrotum and scrotal septum, then external spermatic fossa, cremasteric muscle, cremaster fossa, internal spermatic fossa, and vestige of processus vaginalis. This is the obliterated part of the processus vaginalis. Next, these are the contents of the spermatic cord. That is very important. Three fossa layers: external spermatic fossa, cremasteric fossa, internal spermatic fossa. Three arteries are present: testicular artery, cremasteric artery, artery to the ductus deferens or artery to vas. Okay. Three nerves: genitofemoral nerve, ilioinguinal nerve, and sympathetic plexus, sympathetic autonomic plexus. And three other structures are also present: lymphatic vessels, vas deferens or ductus deferens, and pampiniform plexus of veins. Okay. So these are the contents of the spermatic cord. Very frequently asked on Viva OSPI. Okay. Next. Okay, next we go to the vas deferens. It is a cord-like structure, can be palpated between the fingers and thumb in the upper part of the scrotum. It is a thick-walled muscular duct and that transport the spermatozoa from the epididymis to the urethra. That is the function of vas deferens. Next is the testicular artery. It is a branch of abdominal aorta. We are discussing the contents of the spermatic cord in details. Okay. So first we discuss the vas deferens. Then testicular artery is branch of abdominal aorta. It is long and slender. Descends on the posterior abdominal wall. You will see in the dissection of posterior abdominal wall. Okay. Testicular artery. It traverses the inguinal canal and supplies the testis and the epididymis. Next, testicular veins. These are the extensive venous plexus is present, the pampiniform plexus of veins, and they leaves the posterior border of the testis. As the plexus ascends, it becomes reduced in size so that at about the level of deep inguinal ring, a one single testicular vein is formed. And on the two sides, right and left side, drainage of this testicular vein is different. That is important for your Viva and MCQ. Okay. On the left side, it drains into the left renal vein, and on the right side, it directly drains into inferior vena cava. Left renal vein again drains into inferior vena cava. Okay, so drainage on the two sides are it is different for testicular vein, but arteries are branched from abdominal aorta on the two sides. Okay, next. Next is covering of the spermatic cord. Covering of spermatic cord has three concentric layers of fossa derived from the layers of anterior abdominal wall. Each covering is acquired as the processus vaginalis descends into the scrotum through the layers of the abdominal wall. Next, these are the three coverings. External spermatic fossa derived from external oblique aponeurosis attached inguinal ring. Cremasteric fossa is derived from internal oblique muscle, and internal spermatic fossa is derived from the fossa transversalis and attached to the margins of the deep inguinal ring. Next, now inguinal hernia. What is hernia? Definition of hernia is asked in your Viva. Okay, what is hernia? Hernia is the protrusion of part of the abdominal content beyond the normal confines of the abdominal wall. Okay, so that is definition of hernia. Hernial coverings are formed from the layers of abdominal wall through which the hernial sac passes. Next, see, this is one schematic diagram. Inguinal ligament, external oblique, internal oblique, transversus abdominis, fossa transversalis, okay, and the peritoneum. So, through the canal, if the herniation occurs through the deep inguinal ring, it is known as, and see this deep inguinal ring is lying just lateral to the inferior epigastric vessels. These are the inferior epigastric vessels, okay. So, if the herniation occurs lateral to the inferior epigastric vessels or through this deep inguinal ring, that is known as indirect inguinal hernia. And if the herniation occurs medial to this inferior epigastric vessel, that is known as direct inguinal hernia, and that occurs through a triangle that is named as Hasselbalch's triangle. You have to know the boundary. We will learn the boundary. Next. So, inguinal hernia is protrusion of contents of abdominal cavity through the inguinal canal. See, this gut is entering through the deep inguinal ring, passing through the inguinal ring and entering into the upper part of the scrotum. Okay, there will be swelling in this patient in the inguinoscrotal region, and the swelling increases during coughing. Okay, so we have to check. So, an inguinal hernia is protrusion of contents of abdominal cavity through the inguinal canal, bulges through a weak area in the lower abdominal muscles, and an inguinal hernia appears as a bulge on one or both sides of the groin. An inguinal hernia can occur any time from infancy to adulthood. An inguinal hernias tend to become larger with time, okay, due to straining. During defecation, micturition, you have to strain, so hernia will increase. Next, inguinal hernias are more common in males. We have learned femoral hernias are more common in females, but inguinal hernias are more common in males. And in the case of female, the opening of superficial inguinal ring is smaller than that of the male. That is one reason why it is more common in males. It can come as a explain why. Okay. As a result, the possibility for hernia through the inguinal canal in males is much greater because they have a larger opening and therefore a much weaker wall for the intestines to protrude through. Next, what are the parts of the hernia? Hernia consists of 4 parts: the hernial sac, the contents of the sac, covering of the sac, and neck of the hernia. Okay, according to the content of the sac, name of the hernia is different. Hernial coverings are formed from the layers of the abdominal wall through which the hernial sac passes. See, Emaant's hernia, content of the hernial sac is vermiform appendix. Okay. In Litter's hernia, content of the hernial sac contains Meckel's diverticulum. Okay. Meckel's diverticulum is a extension from the small gut. Okay. You will learn during the abdomen. So, contents are different in different hernias. Next. Next, you have to know the boundaries of Hessel's-Wack triangle. In direct hernia, herniation occurs through this Hessel's-Wack triangle. Inguinal triangle or Hessel's-Wack triangle is an area of the anterior abdominal wall bounded by the inferior epigastric vessels laterally, inguinal ligament below, and lateral border of the rectus abdominis medially. And direct inguinal hernia leaves the abdomen through this triangle. Next. See, this is the triangle, this yellow one, okay. See, this is the midline of the abdomen, here is the rectus abdominis muscle. So, medial boundary is formed by the lateral border of rectus abdominis muscle. Lateral boundary is formed by the inferior epigastric vessel and base of the triangle is formed by the inguinal ligament. Okay, so these are the boundary of Hessel's-Wack triangle. Direct hernia occurs through this triangle. And indirect occurs through this deep ring. Okay, deep ring is lying lateral to the inferior epigastric artery. Okay, understood? See here the vas deferens, veins, all these testicular artery, all this is entering into through this deep ring. Next. So these are the boundaries of the Hessel's-Wack triangle. Medial border by the lateral margin of rectus sheath, also called linea semilunaris. Okay. Another name of lateral margin of rectus sheath. Superolateral border is formed by the inferior epigastric vessels. Inferior border or base is formed by the inguinal ligament, sometimes referred to as Popper's ligament. And you can remember like a mnemonic like RIP, rectus sheath, inferior epigastric vessels, Popper's ligament. Okay. As direct inguinal hernias, reap directly through the abdominal wall. Okay. Next. Okay. So what are the, if inguinal hernia comes as a short note, you have to write both direct and indirect hernia. Okay, and draw schematic diagram. You practice coverings of hernial sac in direct inguinal hernia, indirect inguinal hernia. It is asked in your theory question. Okay. To practice diagram, related diagrams. Okay, so inguinal hernia is of two types, direct and indirect, which are defined by their relationship to the inferior epigastric vessels. Direct hernia occurs medial to the inferior epigastric vessels when the abdominal content herniates through a weak spot in the fossa of posterior wall of inguinal canal and which is formed by the transversalis fossa. An indirect inguinal hernia occurs when the abdominal contents protrude through deep inguinal ring lateral to the inferior epigastric vessels and may be caused by the failure of embryonic closure of the processus vaginalis. Okay, that is the main cause for indirect inguinal hernia. Next, indirect hernia, inguinal hernias are mainly congenital hernia. Okay, that means they stays from birth. More common in males than in females. Indirect hernias are most common type of inguinal hernia and more common on the right side. Neck of the hernial sac lies at the deep inguinal ring. Premature infants are specially at risk for indirect inguinal hernia because abdominal wall muscles are not properly developed, and processus vaginalis is patent because there is less time for processus vaginalis to obliterate. Okay, so there will be direct connection with the peritoneal cavity, and contents of abdomen like gut or like appendix, mucus diverticulum, etc. can enter through this direct connection. Next, in male fetus, the spermatic cord and both the testicles starting from an intra-abdominal location normally descend through the inguinal canal into the scrotum. That's why inguinal canal is needed, okay, for descent of this testis. Descent of testis also your theory question that will be discussed in the last part of the abdomen, okay. Descent of testis, what are the factors helping in descent of testis, all those are important. So in male fetus, the spermatic cord, both the testicles starting from an intra-abdominal location normally descend through the inguinal canal into the scrotum and the sac that holds the testicles. And sometimes the entrance of the inguinal canal at the inguinal ring does not close as it should just after the birth. If it does not close just after birth, it will leave a weakness in the abdominal wall. Fat or part of the small intestine slides through the weakness into the inguinal canal, causing a hernia. And in females, an indirect inguinal hernia is caused by the female organs or the small intestine sliding into the groin through a weakness in the abdominal wall. Female organs means ovaries can enter or part of the small intestine or fat. Okay. Next, direct inguinal hernia caused by connective tissue degeneration of the abdominal muscles. Okay, it causes weakening of the muscles, common in old men with weak abdominal muscles and rare in women. Neck of the hernial sac is wide, and the hernia involves fat or the small intestine sliding through the weak muscles in the groin. A direct hernia develops gradually because of continuous stress on the muscles. Next, one or more of the following factors can cause pressure on the abdominal muscle and may worsen the hernia. What are the factors worsening the hernia? Sudden twist, pulls or muscle strains, lifting heavy objects, straining on the toilet because of constipation, weight gain and chronic coughing. That these factors worsen the hernia. Okay, and during examination of hernia, you have to ask the patient to cough to check whether it is present or not. Okay, see here, this is the hernial sac. Okay, here it has been cut. See, this intestine is passing through the deep ring, passing through the canal, then coming out through the superficial ring, entering into the upper part of the scrotum. This is the spermatic cord and the testis within the scrotal sac. Okay, and this hernial sac is lying just along with this spermatic cord. Here it has been cut open to show the content. See the intestine, pink one, and these are the coverings. Coverings of the hernial sac will be extensum of all these muscles. Okay. Next. Acha, previous one. Okay, see, this is the, here it is shown the direct inguinal hernia. See it lying medial to the vessels. Okay, direct inguinal hernia. And here it is passing through the deep ring mainly, indirect inguinal hernia, lateral to the inferior epigastric vessels to the deep inguinal ring. Okay. Next, see this is the hernia sac coming out through the superficial inguinal ring, passing through the deep ring, then passing through the canal, then coming out through the superficial ring. And these are the contents of the spermatic cord. So all these coverings will be the covering of the hernial sac, okay, that was covering the spermatic cord or forming the walls of the canal. Next, so indirect inguinal hernia, most common form of hernia, believed to be congenital in origin. Hernial sac is remains of processus vaginalis, enters the inguinal canal through the deep ring lateral to the inferior epigastric vessels. It may extend part of the way along the canal or as far as the superficial inguinal ring. That is the extent. Next, see, oh, this one is the direct inguinal hernia, indirect inguinal hernia. Next, so if the processus vaginalis has undergoes no obliteration, the hernia is complete and extends through the superficial inguinal ring down into the scrotum or labia majora. And under these circumstances, the neck of the hernial sac lies at the deep inguinal ring, and it is 20 times more common in young males than in females. This ratio is important, 20 in male, 20:1, male and female ratio. It is more common on the right side. Next, direct inguinal hernia composes about 15% of all inguinal hernias, common in old men with weak abdominal muscles, rare in women. Hernial sac bulges forward through the posterior wall of inguinal canal, medial to the inferior epigastric artery. Okay, relation is important, and neck of the hernial sac is wide. Next, okay, see this peritoneal cavity, it is connected via the transversus processus vaginalis with this sac. Okay, this part is known as tunica vaginalis. Only this part remains patent, and this tract which was continuous in fetal life, it is obliterated. If it is not obliterated, then the abdominal cavity contents the intestine or other structures can pass through this processus vaginalis, okay, and forming the indirect inguinal hernia. And this is the descent of testis. Testis was lying in the abdomen, posterior wall of abdomen, then is passing through the inguinal canal to descend into the scrotum, okay. And this is the cord gubernaculum of testis, helping in descent of testis. Next, okay, that's all. Okay, any queries? So, clinical aspect for the inguinal canal is this hernias, okay, direct and indirect inguinal hernia. You have to know the coverings. You have to remember the coverings of the abdominal wall, and you have to know where it is passing through, okay, through the Hasselbeck triangle, medial to the inferior epigastric vessels will be the direct hernia. Passing through the deep ring, lateral to the inferior epigastric vessel will be the indirect inguinal hernia, okay. Okay, so you have to know the different boundaries of the inguinal canal, that is important long question. Spermatic cord is important short note, okay, and different hernias can come in your questions. Part of long question or can be given as a short note also, and some part of this can come as I explain why. So these are the questions asked from this area, okay, and you practice diagram for the coverings of different hernias, okay. Okay, any queries? Okay, that's all for today. Thank you. Okay.
Today we are going to discuss metabolism of amino acid. In the previous class we discussed the catabolism sections. As you know, in the metabolism there is catabolism and anabolism. Okay. As I told you many times that proteins are long chains of amino acid which are linked together by peptide bonds. If the protein is breakdown, then there is a separation of amino acid, and we classify amino acid on the basis of their structure, on the basis of their special functional group which they contain. Okay, as you already know that amino acid is majorly classified in 7 sections. simple amino acid, branch chain amino acid, hydroxyl amino acid, sulfur containing amino acid, aromatic amino acid. Okay? And as your lecture classes, you separately study these metabolism of amino acid on the basis of their structure. The first one is glycine. It is simple amino acid. It is simple amino acid. Okay? After then, branch and amino acid, you will separately study this on the basis of the structure. And today we are going to discuss amino acid of sulfur containing amino acid. Sulfur containing amino acid, which is what? Methionine, cysteine and cysteine. Methionine, cysteine and cysteines. How these cysteines are formed? By the two molecule of cysteine. By the two molecule of cysteines. Okay? So let me discuss one by one all these metabolism in detail. Methionine, sulfur containing amino acid, methionine, which is an essential amino acid. Okay? And other one is cysteine, and cysteine. So these are sulfur containing amino acid. As I told you, sulfur containing amino acids, that means they carry sulfur molecule in their structure. If we generally see the structure of amino acid, this is center carbon atom which contain carboxyl group on one side and amines group on the other side. But in these cases, they contain sulfur in their structure. Okay. So we discuss these glucogenic amino acid. This is one of the most glucogenic amino acid. Okay. We discuss this metabolism is majorly in three main heading. The first one is transmethylation of methionine. Transmethylation of methionine. Students, this is for your real concept that in the metabolism, the metabolic pathway in large sections. In large cascade pathways occur in your book. How will you remember? कैसे याद करेंगे उसको? Then you can divide this metabolic pathway majorly in 3 points, 4 points. Okay. The first point of the sulfur containing amino acid is transmethylation of methionine. Second one is homocysteine synthesis. This is second one. And third one is degradation. Okay. So this is the three major heading in which we studied this metabolic pathway. Understand? First is how these cysteines and cysteines are formed. This is a major concept of this metabolic pathway. And after the synthesis, how it is degraded, where it is uses. As I already tell you, it is a glucogenic amino acids. That definitely means that it can synthesize a substrate which directly participate in the formation of glucose. Okay? So we discuss one by one, and the students. So you write in your copy and understand well. The first one is methionine. Methionine perform reactions of transmethylation. That means transfer of methionine group and formation of SAM. Formation of SAM. SAM stand for S adenosine methionine. S-adenosine methionine. This being the first step of this metabolism. Methionine is perform these reactions with the help of enzymes. Methionine adenosyl transferase. Adenosyl transferase. In these reactions, it required ATP for formation of two inorganic phosphates. So this being the first step, S-adenosine methionine. It's we called universal methionine donor. You write in your notes, this is called universal methionine donor. Okay? Now, in the next step, methyl transfer and formation of S-adenosine homocysteine. S-adenosine homocysteine. Here removal of one methyl group. Okay. Now, homocysteine is formed, S-adenosine homocysteine. Okay. So, in the next step, there is formation of homocysteine with the help of enzyme homocysteine adenosynthetase. Homocysteine adenosynthase. Okay. From up to these reactions, there is formation of homocysteine. All of you see, Methionine is firstly converted into SAM. SAM is converted into S-adenosine homocysteine. Homocysteine is converted into homocysteine. And these homocysteine, with the help of enzyme methionine synthetase, it forms methionine. With the help of enzyme methionine synthetase, it forms methionine. And for this reaction, here we required vitamin B12. Now you tell me the name of vitamin B12. Cyanocobalamin. What is the coenzymatic form of this vitamin B12? This is THF, tetrahydrofolate. Okay, tetrahydrofolate. So with the help of THF, it can convert this tetrahydrofolate. We see some this reaction from this also slide. Okay, so you well understand. This is transmethylation. This is the first step of this metabolic pathway, in which transfer of methyl group from methionine to the acceptor molecule is known as transmethylation. Okay, and the methyl group of methionine become available for transmethyl only in the active form of methionine. This is called, we call active form, that is SAM. I already tell you this reaction in the first step, SAM. Okay. Now this is the reaction. You will see methionine with the help of ATP, it forms S-adenosyl methionine. You will see also in this reactions there is attachment of active methyl group. Okay, so this is the first step of this reaction, transmethylation. Okay, now in the second steps, conversion of demethylated portion of methionine to cysteine and cysteines. Now from L-methionine it is converted into S-adenosine methionine, and in the next steps I already tell you that it converted into S-adenosine homocysteine, and lastly into homocysteine, and these homocysteine again converted into methionine. This can form this reaction with the help of enzyme homocysteine methyl transferase. Homocysteine methyl transferase, sorry, I will write some reaction. Homocysteine methyl transferase, methyl transferase. And for this enzymatic reaction, what we required? We required coenzyme. Which coenzyme? THF. That is N5-methyl THF to tetrahydrofolate. Okay. So there is one major question comes in their exam, folate trap. If there is a deficiency of this enzyme N5-methyl tetrahydrofolate not forming tetrahydrofolate. So this condition is referred as folate trap. This condition is referred as folate trap. Okay. Now in the next step, there is the formation of cysteine group. Okay, let me discuss firstly in the board, then you will see the slide. You will better understand after that. Okay. इन सारे मेटाबॉलिक पाथवे को आपको लिख लिख के याद करना पड़ेगा. यू हैव टू लर्न ऑल दिस मेटाबॉलिक पाथवे विथ इन रिटन इन योर कॉपी, अदरवाइज इट इज फॉरगेटेबल. बायोकेमिस्ट्री इज अ वोलेटाइल सब्जेक्ट. अंडरस्टैंड? आज पढ़ा कल गायब. क्या खाया कुछ पता नहीं, खाया पिया पचाया. तो इसको क्या करना है, यू हैव टू लर्न ऑल दिस मेटाबॉलिक पाथवे विथ रिटन इन योर कॉपी. जो पढ़ा रहे उसको पढ़ो, कंसेप्ट क्लियर करो. ठीक है. नाउ in this reaction homocysteine combined with serine, don't talk, homocysteine combined with serine with the help of enzymes cystathionine beta synthetase, cystathionine beta synthetase, it forming cystathionine. This reaction is also PLP dependent. PLP stand for last bench. PLP stand for एटलीस्ट इतना तो रिस्पॉन्स देना चाहिए. पीएलपी का नाम आना चाहिए आप लोगों को. ये आगे की 4 लाइनें बोल रही हैं, पीछे वाले सब गायब है. बैक बेंचर्स. What is the chemical name? Which vitamin stand for PLP? PLP is basically vitamin B6, pyridoxal phosphate. Okay. Now in the next step, cystathionine is converted into cysteine. Cystathionine is converted into cysteine by the enzyme cystathionase. Cystathionase. It is again PLP dependent reaction. PLP dependent reaction. Understand? So there is formation of cysteine, and these cysteine going to the next step for the formation of combined with homoserine. Okay. Combined with homoserine, it forming proponyl CoA. Proponyl CoA, and these proponyl CoA forming succinyl CoA, and it directly enter into the TCA cycle and produces energy. Okay. अंडरस्टैंड? यहां तक क्लियर हुआ? इसका मतलब क्या हुआ? व्हाट डज इट मीन? इट्स मीन दिस इज अ ग्लूकोजेनिक अमाइनो एसिड. दिस इज ग्लूकोजेनिक अमाइनो एसिड. ओके. सो अब यहां पे देखते हैं स्लाइड में. व्हेन इट्स कंबाइंड विथ सेरीन, इट फॉर्म्स cystathionine. And these cystathionine combined with homoserine, it forms cysteine. After this reaction, homoserine deaminase is formed alpha ketobutyrate, proponyl CoA, methyl CoA, succinyl CoA, and directly TCA. मैंने यहाँ पे कुछ स्टेप स्किप कर दिए, आप लोग ये लिख लेना, कोई इशू नहीं है. Okay. I does directly mean that with a combination of serine, it forming cysteine, and with cysteine, it directly enter in the TCA cycle for the production of energy. Okay. समझ में आया यहां तक? नाउ वी आर कंप्लीटिंग हियर सिंथेसिस पार्ट, ओनली सिंथेसिस ऑफ सिस्टीन फ्रॉम मिथ्योनिन, अंडरस्टैंड? अब यहां पे आता है डिग्रेडेशन, डिग्रेडेशन ऑफ सिस्टीन। सिस्टीन बन गया, अब सिस्टीन का डिग्रेडेट कैसे होगा? क्या ऐसा प्रोडक्ट बनेगा जिसमें सिस्टीन यूटिलाइज हो सके? बॉडी में सिस्टीन कैसे रिलीज करेगा? भाई कोई चीज बनेगी उसका यूटिलाइजेशन तो होगा कहीं ना कहीं, ठीक है? तो डिग्रेडेशन देखो, डिग्रेडेशन थोड़ा टफ है, ध्यान से देखना। Now degradation. This is cysteine. Firstly, it form mercaptoethanolamine. Mercaptoethanolamine. It form a secondary product in the degradation. It form mercaptoethanolamine, and these mercaptoethanolamine is with the help of pantothenic acid. With the help of pantothenic acid, it form acetyl-CoA. This is the first utilization of these cysteine molecules. Okay, these cysteine molecules. And other one is formation of pyruvate, and these pyruvate directly form glucose. Okay, and this one, with the help of enzyme cysteine deoxygenase, citric acid, sulfite, and this citric acid is converted into taurine. This taurine is used. Taurine in bile salt formation, sodium glycolate, sodium taurocolate. This is the composition of bile salt where taurine is used. Okay, and this sulfide is used in formation of phosphoadenosine phosphate. And this is generally used for the formation of MPS. MPS means mucopolysaccharides. Formation of MPS, mucopolysaccharides, and these PEPs also used in detoxification. Detoxification. When you read the topic xenobiotics, then there is use of this PEP, phosphoadenosine pyrophosphate. MPS. Okay, so this is the degradation. This is the degradation of this amino acid. Okay, Students, see this. With the help of enzyme cysteine reductase, there is a formation of cysteine. So for the formation of cysteine, what is required? 2 molecules of cysteine. Okay, it is interconvertible reactions, interconvertible reaction. So this is the reaction. For this reaction, what we required? We required cysteine reductase, and cysteine can be catabolized by two routes. I can mention here directly. Now you see one by one that cysteine. All of you see students, this slide. Cysteine is converted into beta mercaptopyruvate by cysteine transamination reaction, and these can forming pyruvate and hydrogen sulfide. Okay, and directly it forms sulfide. Here I can form sulfide, and these form sulfate, and these sulfates forms 2 molecules PEPs, active sulfates, and rather than these sulfate can excrete it in the urine. Understand? So what is the application of this degradation? That means the major cysteine is forms is excreted out in the urine in the form of sulfate. Okay, by this reaction cysteine transamination forming beta mercaptopyruvate, and this pyruvate is directly used for the formation of glucose. As I already tell you that in this reaction all the things are happen, and in the board I can read, I can mix separately. Okay, clear hua? Any question from your side? Now, direct oxidative pathway to catabolism of cysteine, it forming taurine, L-cysteine, cysteine sulfide, beta sulfide, by desulfuration formation of PEPs and formation of taurine. So in this book, in this slide, there are 2 pathways. The first pathway we called transamination pathway, second pathway is called direct oxidative pathway. Okay, either in some of the books it is given directly as I write here. In some of the books they mention has 2 pathways. Okay, here reduced glutathione is required for this. Reduced glutathione is required for these reactions. Okay. Now, importance of cysteine. We understand all the clinicals related with that. Importance of cysteine, that glucogenic amino acid involved in the formation of glucose. It is dietary source of sulfur, and it is for formation of cysteine, formation of insulin. Why it is called insulin? Why it is required for formation of insulin? Because when you see the structure of insulin, there is the presence of sulfur bonds. Huh? So these sulfur bonds are provided by cysteine. Understand? So that's why it is helpful for the formation of insulin, for formation of coenzyme A, glutathione, vasopressin. Okay? So it is for detoxification process because it contains glutathione. Now, metabolism related with metabolic disorder, the disorder related with this metabolic pathway. Are you understand what I read up to this? Today we are going to discuss the metabolism of sulfur containing amino acid, which is methionine. Methionine forming which molecules? Cysteine and cysteine. These cysteines are formed by the 2 molecules of cysteine with the help of enzyme cysteine reductase. Concept. Now, uses of this methionine, it is a sulfur containing amino acid, glucogenic amino acid, it is an essential amino acid. Okay. So what we studied in the reaction, the methionine firstly do the transmethylation reactions. In transmethylation reaction, they forming which molecule? S-adenosine methylation. S-adenosine methionine. This is a universal donor of methionine. With the help of enzymes, which enzyme is required here? S-adenosine transferase. S-adenosine transferase is required, and after this reaction, there is a next step, formation of S-adenosine homocysteine. S-adenosine homocysteines are formed because homocysteine here is forming. So in the next step, formation of cysteine, and this cysteine directly participate in the formation of methionine with the help of enzyme vitamin B12. Majorly for the reaction for the coenzymatic form, of vitamin B12 is tetrahydrofolate, THF. It is a very important, vitamin B12 is a very important vitamins. Okay. Now understand the metabolic disorder. With this metabolic disorder, the first one is cystinuria. Cystinuria is a common involvement of amino acid transport. Cystinuria is an inherited disorder in which kidney tubules fail to reabsorb the amino acid. Cystinuria. As the term you listen, what do you make the concept? That means presence of cysteine in the urine. Presence of cysteine in the urine. Why it is cysteine comes in the urine? If either it is not metabolized, if either it is not reabsorbed from the renal tubules, because major metabolic pathway are forming GFR, glomerulofiltrate, and after the glomerulofiltrate, it can reabsorb in the renal tubules. Maximum quantity become reabsorbed. If it is not reabsorbed, then directly it is excreted in the urine. But question is that why it is excreted? So first reason is that it is not reabsorbed. It is not reabsorbed. Which amino acid is not reabsorbed? Ornithine, arginine, lysine. For this you can make a mnemonics called COL. For remember, याद करने के लिए आपको याद होना चाहिए. आपसे एक्सटर्नल पूछेगा what is cystinuria. So you have to easily remind that COL is a word. COL stands for cystinuria because there is no reabsorption of ornithine, arginine and lysine. Ornithine, arginine and lysine. It is not reabsorbed. Okay? तो COL याद रहेगा तो क्या याद रहेगा? cystinuria याद रहेगा. ठीक है? It is characterized by massive urinary excretion of cysteine, ornithine, arginine and lysine. What are the causes of this? The amino acid filtered by the glomerular, reabsorbed by the pulmonal renal tubules by specific carrier protein. The cystinuria defect in this carrier system leads to the excretion of all these amino acid. That's it's required some co-transporter for their reabsorption. These co-transporters have been defect. That's why it is not reabsorbed. Okay, that's why it is present in the urine. Student, make your concept yourself. आपके concept आपको खुद बनाने हैं. समझ में आ रहा है? What I tell you? I will tell you. If I will tell cystinuria, then you understand that something mnemonics COL is there. COL stands for cysteine, ornithine, arginine and lysine. It is not reabsorbed by the renal tubules, then it is excreted in the urine. Okay. Now clinical feature. These are the clinical feature of this cystinuria, that it forming cysteine calculi, formation of calculus. Calculus is basically stone formation. Okay. Either it is a kidney stone or urinary stone. They depend on these renal tubule leads to the obstruction, infection and renal insufficiency. Cystinuric patients. Okay. So the patient who having calculus in their renal area can causes such type of defect. Okay. Treatment is large amount of water you will take and other things. Okay. Now cystinosis. This is second one, cystinosis. It is lysosomal disorder. First one is cystinuria. Second one is cystinosis. It is lysosomal disorder. It is okay. It causes defective carrier that transports cysteine across the lysosomal membrane from lysosomes to the cytosol. Lysosomes to the cytosol. solve. And these are the clinical feature of this. Clinical features means it forming crystals. First thing, it is amino aciduria, and if a person having these, there may be chances of death. If diseases persist, if it is not manageable, then it is easily causes. Okay. क्या पढ़ा रहा हूँ? कहाँ है दिमाग? क्या बताया अभी? Cystinuria, cystinosis. Okay. Now last one, homocystinuria. It is very important. Homocystinuria, that's the level of homocysteine is increases in the blood. Okay, and it's excreted in the urine also. Homocysteine is a group of disorder of methionine metabolism. It is characterized by high blood level of homocysteine and urinary. In both blood and urine, the level of homocysteine is increased. Excretion rate in the urine is increased. They measure having 4 defects. You understand? Major 4 defect of homocystinuria. Major 4 defect of homocystinuria. आपको आना चाहिए ये चीज. कौन कौन से डिफेक्ट है? ये डिफेक्ट है. That homocystinuria first is by cystathione beta synthetase. First by beta synthetase, cystathione beta synthetase. Homocystinuria second, synthetase and methyl tetrahydrofolate. Homocystinuria second and methyl tetrahydrofolate. बहुत इंपॉर्टेंट टर्म आ रहा है. Synthesis of N-ethyl methyl tetrahydrofolate. That means it is a condition of folate trap. Homocystinuria second, deficiency of methyl B12. Homocystinuria fourth, defective intestinal absorption of vitamin B12. ओके जब विटामिन B12 हो गया आपका, हाँ B12 कंप्लीट हो गया, उसमें एब्जॉर्प्शन पढ़ाया था उसमें, फिजियोलॉजी में नहीं, इसमें बायोकेमिस्ट्री में नहीं पढ़ा नहीं था, कोई बात नहीं, उसमें है, उसमें देखेंगे, ठीक है. तो दीज ऑल आर द डिफेक्ट ऑफ दिस ऑल दिस मेटाबॉलिक डिसऑर्डर. होमोसिस्टिनुरिया फर्स्ट, होमोसिस्टिनुरिया सेकंड, होमोसिस्टिनुरिया थर्ड, होमोसिस्टिनुरिया फोर्थ. ऑल थ्रीज आर रिलेटेड विद विटामिन B12 एंड देयर कोएंजाइम. इस तरीके से याद करेंगे. थर्ड, फोर्थ एंड second, third and fourth, it is related with vitamin B12. In the second, there is enzymes, deficiency of N5-methyl tetrahydrofolate, deficiency of methyl B12, deficiency of intestinal absorption of vitamin B12. So all these are related with homocystinuria. Homocystinuria are what? It is a high level of homocysteine in the blood and urine. Okay. Now we understand metabolic blocks of homocystinuria with this that contain N5-N10 methyl tetrahydrofolate, and with the help of enzyme, this enzyme methylene reductase. These are the main enzyme. If the enzyme is deficient, this causes homocystinuria second. Okay, please take the click of this slide. यहाँ से आपको सारी डिसीज क्लियर हो रही है, ठीक है, विद द हेल्प ऑफ एनजी. अगर ये एंजाइम डेफिशिएंट है तो कहीं ना कहीं आपका ये सारे मेटाबॉलिक डिसऑर्डर कॉज होंगे. होमोसिस्टिनुरिया फोर्थ, होमोसिस्टिनुरिया थर्ड, होमोसिस्टिनुरिया सेकेंड. ओके, दिस ऑल आर द symbol of blockage. Blockage means if there is vitamin B12 deficiency is here, so there is no transfer of methionine group, and this leads to homocystinuria third. And if there is no absorption of vitamin B12, this causes homocystinuria fourth. Okay, these all are the causes, and these are the causes cystathione beta synthetase. This causes homocystinuria first. Now this is a major important slide with the what is the symptoms which arises in the accumulation of these homocysteine. These are ectopia lentis, dislocation of lenses in the eye, first and major symptoms. Dislocations of the eyes. It is for causes osteoporosis, mental retardation, and thrombosis. Directly, student, basically in homocystinuria, it causes mental retardation, osteoporosis, CVS, cardiovascular, okay, and these can also causes coronary artery disease. This is CAD, which is myocardial infarction. Okay. Because why it is causes cardiovascular disease, why it is causes myocardial infarction? Because these homocysteine can directly interpret in the formation of collagen. For the formation, what is required? Lysyl oxidase is required. Lysyl oxidase is required for the formation of collagen. And when there is high level of homocysteine, this can interpret the formation of collagen, and due to this aggregate the LDL molecules. LDL is low density lipoprotein molecules. In LDL, what is major portion is there? Cholesterol. Okay, so they can accumulate LDL in a high amount, and when there is accumulation, there is a process of thrombosis, and this leads to a disease, myocardial infarction or pulmonary embolism or stroke. कोलेजन फॉर्मेशन को डिस्टर्ब किया होमोसिस्टिनुरिया ने, उसकी वजह से क्या हुआ? आपका एलडीएल एक्यूमुलेट हुआ, एलडीएल एक्यूमुलेट हुआ तो क्या हुआ? थ्रोम्बोसिस हुआ, और थ्रोम्बोसिस हुआ तो क्या हुआ? देन अल्टीमेटली लीड टू द फॉर्मेशन ऑफ myocardial infarction. Okay. Now treatment क्या है इसका? Treatment, if you provided B complex to such patient, okay, B complex, B6 especially, pyridoxine if you provide it, and low diet of methionine supplement with cysteine, and vitamin B12 is given instead of vitamin B12 deficiency. So these all are the dietary treatment of such patient. It is not symptomatic treatment, it is dietary treatment to avoid this disease, okay. So all these are what? These are sulfur containing amino acid metabolism, Okay. So we can revise one by one from this and we finish the topics. So now you understand with one by one what we read today, what we understand today. Metabolism of sulfur containing amino acid. I summarize the topic. In metabolism of sulfur containing amino acid, it majorly contains methionine. Methionine is directly from cysteine and cysteine. Cysteine is a two molecule of cysteine. Because it contains sulfur containing amino acid, it is helpful for the formation of vasopressin, for the formation of insulin. Okay, and it is a glucogenic amino acid. Ultimately, it forms the glucose. Okay, so what these three sulfur containing amino acid are there? Cysteine, cysteine, and methionine. Where methionine is an essential amino acid, where cysteine and cysteines are non-essential. So what does it mean? What does it mean? It is synthesized within the body, cysteine and cysteine. Okay. So these cysteine and cysteine are synthesized from two amino acid, methionine and serine. As I directly know, अगर आपको पता है कि serine से cysteine और cysteine बनता है, then you easily write the metabolic pathway. You easily write the metabolic pathway. ठीक है? अभी समझना, बनाने की कोशिश करना, दिमाग में चीजों को बिठाना सीखो. ये नहीं है कि यहां से जाके भूल गए. आफ्टर आउट फ्रॉम द लेक्चर क्लासेस यू विल फॉरगॉट ऑल दिस थिंग्स. नो, you kept in your mind what I will say. So for the starting of metabolism, what we required? We required methionine, and this methionine is firstly converted into SAM. SAM मूवी देखी है? SAM नाम सुना होगा. अभी एक मूवी आई है सैम बहादुर. तो कुछ ऐसा कंसेप्ट याद रखना. सैम स्टैंड फॉर एस एडेनोसिन मिथियोनिन इज ट्रांसफरेशन रिएक्शंस. ओके, लिसन, ध्यान से सुनो. मिथियोनिन इज फर्स्टली कन्वर्टेड इनटू सैम एंड सेकेंडली कन्वर्टेड इनटू SAH, and this SAH is converted into homocysteine, and homocysteine is converted into cysteine, and this cysteine directly converted into methionine. Okay, this is the first part of this. Now in the second part, these homocysteine combine with serine and form cystathionine, and this cystathionine directly forms cysteine, and combined with homoserine it forms propanol CoA, and again it proved that it is a glucogenic amino acid. Again it proved that it is a glucogenic amino acid. Okay. Now transmethylation reaction. This is the reaction, formation of SAH, S-adenosine transmethylation reaction, homocysteine, and these homocysteine methyl transferase, it can lead to L-methionine. If there is vitamin B12 deficiency is there, these folate trap, this N5-methyl tetrahydrofolate is not converted into tetrahydrofolate, and these N5-methyl tetrahydrofolate become accumulate. This condition is referred as folate trap. Okay. Now in the second reactions, these cystathione is combined with serine. It forms cystathione. Cystathione again break down this molecule cysteine, and with these two molecules by cysteine reductase enzyme. Which enzyme is there? Cysteine reductase. It forms cysteine, and these homoserine forming alpha ketobutyrate and propanol CoA, and these going to the TCA cycle for the production of energy. Okay, understand? Now in the catabolism section, catabolism means how it is used. I directly make this how it is used. It is majorly used for formation of bile salt by taurine, formation of mucopolysaccharide by the formation of PEPs. Okay. as I clearly told you, this one formation of beta mercaptopyruvate, and these beta mercaptopyruvate form pyruvate, okay, and these form sulfite. These can produce sulfate group, which is directly excreted in the urine, first one, or it is directly participate in the formation of mucopolysaccharide PEPs, okay, and these can form taurine. Taurine is basically a component of bile salt. Bile salt is formed by sodium glycolate and sodium taurocolate. What is the property of bile salt? It is a emulsification reagent. It can emulsify a fat, helpful for the metabolism of fat. Okay, bile salt is very important. Because when there is metabolism of cholesterol, the degradation of cholesterol also helpful for the formation of bile salt. Okay, so these all are the product which is formed by cysteine, taurine, insulin, coenzyme A, glutathione and vasopressin. Glutathione is act as a antioxidant. That's why it is directly participate in detoxification reaction. It can reduce the quantity of hydrogen peroxide. Hydrogen peroxide. Okay. हाइड्रोजन peroxide जो है एंटी एजिंग, ग्लूटाथियोन एंटी एजिंग है, एंटी इंटॉक्सिफिकेशन करता है, डिटॉक्सिफिकेशन प्रोसेस को करता है, ठीक है. दैट्स वाई इट इन्वॉल्व इन डिटॉक्सिफिकेशन मैकेनिज्म. ओके, नाउ inborn disease, the first one is cystinuria. Cystinuria is basically, if the word is comes in your mind, cystinuria, it means the level of cysteine is increases, and it is by defect of renal tubules reabsorption, and there are 4 main amino acid are not reabsorbed. For this you remain the mnemonics COLA. COLA stands for cysteine, ornithine, lysine and arginine. It is not reabsorbed. अगर कोई चीज रीअब्सॉर्ब नहीं होगी तो क्या होगी, यूरिन में एक्सक्रीट हो जाएगी. इट इज एक्सक्रीटेड इन द यूरिन, एंड मेजरली इट इज मेजरली आइडेंटिफाई विद दिस यूरिनरी एक्सक्रीशन. ओके, पहले क्या होता था कि अमाइनो एसिड के टेस्ट करते थे. इन द प्रीवियस क्लासेस देयर इज सिलेबस इन विच यू कैन परफॉर्म द टेस्ट फॉर आइडेंटिफिकेशन ऑफ अमाइनो एसिड, आइडेंटिफिकेशन ऑफ सल्फर कंटेनिंग अमाइनो एसिड. ओके, तो उस बेसिस पे हम आइडेंटिफाई करते थे कि पेशेंट्स को कौन सी डिसीज है. बट नाउ अ टाइम्स देयर रिकरेंस रेट इज देयर इज, इनका जो प्रिवलेंस है काफ़ी कम है, तो इस वजह से इतना नहीं करते हैं. ठीक है, अभी कॉजेस पता है आपको, क्लिनिकल फीचर्स क्या है, फॉर्मेशन ऑफ कैलकुलस विच कैन लीड्स टू द ऑब्स्ट्रक्शन इन्फेक्शन एंड रीनल इनसफिशियंसी. ओके, ठीक है स्टूडेंट्स, यहां तक टॉपिक कंप्लीट होता है. कोई क्वेश्चन हो तो आप लोग पूछ लेना. ठीक है, समझ में आया? थैंक यू.
Okay, so we already have started the urinary system, and we covered the kidney microanatomy in the previous session. We are going to cover the rest of this urinary system, which consists of the 2 of this microanatomy. One is urinary bladder, other is ureter. We have a good news and we have a bad news. Bad news is that we do not have to study the urinary bladder for now because we do not have a slide. Good news is that there is no good news. Bad news in a sense, because though it is not there with us, but still the importance of this content is not anyhow reduced to an extent of microanatomy of this urinary bladder system. We already have covered this kidney system, and we learned about this particular nephrons and etc., the relative things which is related to the kidney and this renal system. Now we are moving to this particular collecting system of these urine, which start with this urinary bladder and this drainage pipe which drains into the urinary bladder. We call them as ureter. We have the right and left ureter, which is carrying the urine from this kidney, which is production house of it, and it transporting to the reservoir, which is the urinary bladder. Now, this particular ureter, which is basically a pipe or tube, which is right side and left side retroperitoneal structure. That means it's pasted on the posterior abdominal wall. So, it's lying on the muscles of the posterior abdominal wall. So, this particular ureter is a kind of like muscular organ. It's a muscular tube. It has a plenty of muscles in there, and it has a movement which is observed in it. We call them as peristalsis, because it has to transport the urine from this particular kidney to down to this urinary bladder. Though the gravity helps it out, but yet it has its own peristaltic machineries to put this particular thing down. So, it is kind of like having an importance of the general anatomy of the ureter is concerned. So, you have to learn this general anatomy of the ureter, but we are going to learn about the microanatomy, which includes this putting this particular ureter in smaller sections and identifying it. Now, remarkable feature about this particular ureter and urinary bladder are principally the same, like the principle of this particular thing is same. That's what is kind of similar. Now, as it is transporting this particular chemical substance or this urine or this liquid substance, the logic of this architecture of this particular ureter or urinary bladder is that there shouldn't be any leaking of the fluid. So, if you have something pipes which is draining the fluid, the basic principles of or the make of the pipe should be like this. It should not be leaking the fluid it is carrying, or else it will be soiling over. So, this particular organ, which is the ureter and as well as the reservoir, which is urinary bladder, is made in a way it should be leak proof, so that the urine is not leaking out through this particular system, or else it will be contaminating, it will be soiling rest of the places. So, this is the basic logic of building of this ureter. So, having kept that in mind, so that we have to make this particular organ or microanatomy of this organ has to be made in a way that should not be having a gross leakage of the urine, neither it should have a micro leakage of this particular fluid or contents. So, that means it may not have a hole, that means it is not leaking, but there might be some kind of micro leaking, that means small amount of the urine it is seeping out, that makes like the foils the part of this particular ureter. So, this particular ureter is like a layered in a way, is pavemented by some kind of epithelium lining which is having that kind of leak proof nature. So, the epithelium or the innermost layer of this particular urinary bladder as well as ureter are made of some cellular element, we call them as transitional epithelium. Now, we learn about transitional epithelium, which means it transforming the shape. This particular transitional epithelium, this kind of tissue is only seen in this particular urinary system. That is why this transitional epithelium or this epithelium cells which is seen in here, we call them as urothelium, which is related to the urinary system. Clear? Now, we have seen this particular kidney, and this particular kidney is draining the thing out through this particular sinus system. Now, the sinus is fitted up with this particular element which is collecting it. We call them as minor calyx, which is small element, then joining to this minor calyces, major calyces which is coming out, and major calyces joining to form the big ureter which is coming out like this. And urinary bladder or ureter has different parts. I am not going into it. So, this is how this particular thing is going down, and it is emptying into urinary bladder. So, starting from the minor calyx to this particular urinary bladder and the outlet of urinary bladder, which is known as urethra. So, that particular some segment of the urethra as well is lined by this kind of epithelium, we call them as urothelium, which is only seen in this region. So, this particular urothelium is nothing but the transitional epithelium. Transitional epithelium, when we started this particular epithelium classification at the beginning of the session, we mentioned about, we emphasize the word transition. That means it is transforming or changing the shape. So, the transitional epithelium is a stratified layer, or appearance to be having stratified layer. That means it may have multiple layers, but this particular multiple layer may appear based on the status of this particular the organ itself. So, if it is empty state, if it is lying, it is more layers we are seeing, rather than it is when it gets distended or stretched out, the cellularity gets also diminished with the stretching. So this kind of thing we call them as transitional epithelium. That means it is transforming to the multi or super multi layer into the smaller or single layer or 1-2 layers. So when you see this particular urinary bladder in a empty state, that means it is in a shrink position. When you see this particular ureter when it is lying in a non-peristaltic stage, it is in a relaxed stage. It has more cellular layer than that of when it is stretched, and when this peristalsis happen, it has less number of cell layers, which is seen in this particular layer. That's why this particular epithelium we call them as the transitional epithelium. Now this particular cellularity layer have got 4, 5, 6 layers, which may be reduced into 2 layers if it is stretched compared to the unstretched or empty status. Second thing is that this particular layer, the lamina propria, which is a connecting tissue layer, which is lying below this particular basement membrane, which is having a tough or thickness is there. And this particular lamina propria is really thick, so that this particular cellular permeations doesn't have. And as it has multi-layer of the cells are there, these particular cells which is very much linked with each other. So this side to side, the 2 cells which are linked with the tight junctions, and the cells which is lying above and below, they are also linked with the tight junctions. So we have these particular cells to glue each other. We call them as gap junction, tight junctions. Gap junction for permitting things. Where you see the gap junctions? When transmission is required. Where we need the transmission? Like muscle cells, neural cells. Where we need the transmissions to happen, move can fastly between the cells. We have this gap junction. That means between the cells we have gaps, and that's why we have this particular cellular connectivity. Cytoplasm was connected. But here we cannot keep the gaps. If you have gaps, it will seep through the water through it and it will soil it out. So we keep this particular cell in a way so that there are no leakage is there. So we have this particular cell glued together with this joining of the cells. We call them as tight junctions. That means they are tightly adherent. We are not allowing any empty spaces between them or any potential space lying in there. So these particular cells in this urothelium, which is lying in here, the cells are glued together and no gap is there. They are having kind of bridging between them. We call them as tight junctions, which is a kind of gluing element which is present in this particular layer. And deep to this particular lamina propria, we have the same muscle layer. The same muscle layer may have more than 1 layer or 2 layers or 3 layers, depending on the organ we are seeing, and adventitia, which is outside most, which is doesn't have that much of similarity or dissimilarity than that of rest of the other organs we have studied. So we have going to emphasize this particular organ in case of this particular epithelium cells, which is special in this and which is a hallmark. As I am saying, this is only found in this particular region, which is starting from the minor calyx, major calyx to this particular ureter to the bladder and the part of the urethra, which is only present in it, which is a kind of like identifying feature. And between this urothelium or the cells, we have a tight junction existing in here. Rest of this, which is not having that kind of tight junctions the way it is tight junctions. And this lamina propria is thick out here. We have this connective tissue, blood vessels emptying in that particular region and supplying this organ. Then we have the muscle layer. Muscle layer, we have seen maybe double layer, triple layer muscles are there. If you have the ureter tube, which is more muscular compared to this particular urinary bladder, which is less muscular, or having different directly muscular layers are there, right? So this is how we are going to talk about. So let's talk about this particular ureter, the microanatomy of this particular thing, and then we are going to talk about this urinary bladder. So straight away we are going to talk about this particular divisions of it. So we divide this particular tube into 3 segments microanatomically. We have the mucosa, that means where the cell lie. Then we have this muscle layer, where these muscles are there. It has to be peristaltic movement which is present. And most outside, which is the adventitia, outside layer, serous layer, which is having these 3 different coats are there. Now we take this particular inner cell first, then we move to the outer wall. So we have this inner cell which is lying here, mucosa, which is composed of 2 elements. One is lamina propria, the connecting tissue below this particular cells, and we have these cells which is a particular cells which is present in here. We call them as transitional epithelium, which is also known as urothelium, because they are only seen in urinary system, not in entire urinary system, but minor calyx, major calyx, ureter, bladder and urethra, right? Then we have the muscle layer, which is smooth muscle of course, but this particular muscle have got 3 different fractions of that. We call them as inner longitudinal and outer longitudinal. In between we have a middle circular layer which is existing in this ureter layer, which is having a more muscle layer which is present. Now, this particular muscle layer, which is predominantly present in the middle portions of the ureter, not in this urinary bladder upper end, ureter upper end or the lower end. So, if you take the sections of this particular middle portions of this particular ureter, then only we can see these three different courses. Rest of the ureter may exhibit outer longitudinal and inner circular, this particular two layers only. Now, outer side layer, which is retroperitoneal outside, serous layer, which is layered by this particular peritoneal lining. So, take this particular mucosa and this particular mucosa, we call them as lining epithelium. The cells which is present in here, we call them as transitional epithelium. Why do you call them as transitional epithelium? Because it transit from one shape to the other shape, looks like. So, when it is empty, this particular cells may be stacked looking like 4 to 5, 6 layers. But when it is stretched, that means when it is filled up with urine, when it distended, this particular layer which is having 4 or 5 layers becomes 1 or 2 layer. So, it is transforming from this 5 layer to the 1 layer. That is why that this particular cellularity we call them as transitional epithelium. So, this particular transitional epithelium is a kind of element which is seen here. Then we have the lamina propria, which is quite thick in this particular region. And this particular lamina propria, which is lying in deep inside, because of this particular lining epithelium which is having multi-layer, they will take a shape of this particular like a folding pattern. So, this particular folding pattern looks like star-shaped area. So, this particular lumen which holding over here looks like a star-shaped lumen because of the folding of this lining epithelium which is comes in it. Then we have the muscle layer, which may be 2 or 3 layers depending on the sections, and then we have outermost layer. So, we take this particular schematic picture, this is how it looks like. You see this particular structure, circular structure, this is a tube which you are looking at. So, this is the lumen, the most inside layer, and then we have this particular lumen, if you see that looks like star shaped because of the folding of this particular layer which is the cellular layer. This cellular layer we call them as urothelium, also known as transitional epithelium. So, this particular transitional epithelium is lying in folds because it is in a relaxed stage or it is in a collapse stage. So, when it becomes stretched, it is distended and dilated. This particular layer, you can see that this much of breadth of these cells are there. If you count that, this is the bottom one, then next one, then next one, then next one. And if you just like layer it, it may look like 4 layer, 5 layer like this. But when it's stretched, it becomes very thin, 1 or 2 layer. So, this particular cells, if you see that the bottom cells, the morphology or the look of these bottom cells are different from the apex cells, but we are not going to talk about that much details. But we understand this particular multi-layer pattern, which is this particular layer is there, and this particular folding is there because of this particular layer. We see that this is the lamina propria, which is the connective tissue there, which is containing this particular blood vessels, lymphatics, nerves, etc., etc. So, this lamina propria is quite thick compared to that. Then we have this particular muscle layer. This muscle layer may be having 1 layer, 2 layer, 3 layers like this, depending on the sections we are there, but doesn't matter. We have the muscle layer which is lying in here. So, we make sure it like muscle layer outside to it, and the adventitia is most outside, which is outside laminating it. Now, this particular lamina propria along with this particular epithelium, which is this mucosa composed of, is making some folds and having this particular fold lumen looking like star shaped lumen. So, that is why it looks like. Now, this particular element, if you magnify it, zoom it, it looks like this. So, this particular cellularity which you are seeing here looking like this to this, which is having multi layers. Now, if you stretch it, pull it from this side and this end, it becomes stretched. So, then this particular 5-6 layers becomes 2 layer. So, that is transiting from the 5 layer to the 2 layer. That is why you call this. Now, between these particular cells, you see that the uppermost cells, which is circular, bottommost cells are flatter. But we do not have to keep this thing in mind, because if you memorize these things, we are going to miss this important details. So, minor details we are excluding out. So, we just memorize this particular epithelium, which is transitional epithelium, also known as urothelium. If it is undistended, relaxed stage, may have multi-layer, 5 to 6 layers. When it is distended, becomes 2 layers. We stop at that point and rest is fine. Then we have this particular connective tissue layer, we call them lamina propria, which is quite thick. Then we have the muscle layer, outer longitudinal, inner circular, or may have 3 layers. So, we stick it to the muscle layers which is present in inside, and then adventitia. This is how it looks like schematically, and this is how it looks like in actual picture when you are going to see that. This is the lumen mucosal folds is folding in here, and then we have this particular muscular layer which is getting in deep to it, and then we have the lamina propria. And you see that thickness of this particular muscle layer which is quite big. Because of this particular muscle layer which you're seeing here, deep to here, you have this cellular layer which is 5-6 layer, then you have the lamina propria, and overlapped by this particular muscle layer, inner circular layer is connecting this particular thing, then outer longitudinal cells layer is there. So this muscle coat is quite thick. Now we have similar kind of tube which is present in our body in a female subjects. We call them as the fallopian tube, also known as uterine tube. So that uterine tube also looks similar like this. But we will see that this uterus, which has the fallopian tube, doesn't have that much of muscularity just like ureter has. So this muscular layer, which is this much thick, we are seeing here, having got 3 tons of the cells, muscle cells are placed there. That's why this is fleshy and very muscular. Compared to the uterine tube, when you're going to learn the uterine tube, we'll put a comparative picture together. So that will help us to identify this particular ureter with this distinguishing with this uterus, uterine tube. So that will help us to identify based on this particular girth or the thickness of the muscle layer. The muscle layer which is quite thick, and this particular urothelium which is lying there, and this particular epithelium is also different in case of this uterine tube as well. But anyways, so we are restricting it for this particular part which is having this particular element which is urothelium which is lying in here. Then we have the muscle lamina propria, then fitting into deep into a muscle layer which is quite thick. So this particular muscle layer is actually penetrating into lamina propria to some extent, and then we have the thick muscle layer have got layered into 2-3 different layers, and then we have the adventitia. And this epithelium we call them as transitional epithelium, and which is hallmark for this urinary system. So this is about this ureter, and if you have to memorize, you have to memorize this basic principles of it: mucosa, muscle layer, and adventitia. This is what we are going to see. The muscle coat in this particular tube is quite thick compared to the other tubes which you are going to learn. Mucosa, which is specific. Now from this region we are moving to the other thing which you do not have, but still it is very important for us to know about, which is urinary bladder, which is this particular reservoir for this urine. And this particular thing also have got this particular similar kind of pattern which you are seeing here. This urinary bladder also have the same morphology architecture. So it has this mucosa, it has this muscle coat, and it has adventitia. This particular mucosa which you are going to see is the same, that same transitional epithelium which is present inside to it, and this particular transitional epithelium is again more layers may be seen compared to the urinary bladder. So we have the transitional epithelium also known as urothelium. Deep to that we have the muscle layer. Now comparative to this particular muscle layer which we have an additional layer we are going to talk about. So we have this muscle layer which is known as inner longitudinal, outer longitudinal, and middle oblique layers. Now the muscles which is present over here we call them as detrusor muscle. This muscle which is seen in this particular urinary bladder we call them as detrusor muscle. We have to keep this particular word in our minds about detrusor muscle which is seen as the muscles of the urinary bladder. So this particular principle of this detrusor muscle that you have to keep in mind, and adventitia is the same which you are seeing in this particular region. Now this particular region of this particular urinary bladder, as we are seeing here, the muscle layer which you are seeing here is having kind of like thickness, usually inner and outer layers which is arranged longitudinally, and middle layer is kind of running obliquely. That means this particular muscle have a bizarre pattern of running. They do not have a particular pattern which is present in this particular layers, and which is having this particular organization. Some of this particular muscle layer which is lying in this region may be transformed to form a sphincter of the bladder. So bladder which is holding the urine for some time, it has a valve. That particular valve is controlling the release of this urine. So this urinary bladder do not have any check valve when it is pouring in. So this particular urinary bladder have got a inflow tube. That means the ureter is bringing the urine to the urinary bladder. We do not have any check valve for the uriner. So no matter how the urine is produced in the kidney, that has to be dumped into the urinary bladder. But the urinary bladder has an outflow check. That means the outflow valve or outflow region, which is the urethra, which is a drainage pipe of the urinary bladder, has a check valve. That means it has a door or it has a valve there, which controls the release of the urine. That means it comes in the urinary bladder and it remains there for some time, and that particular remaining of the bladder urine, which is held or kept in check by some valves. That valves we call them as the internal urethral sphincter. That particular sphincter is formed by this particular muscle which is present in urinary bladder, which is a transform variety. So when you're going to learn the gross anatomy, we'll talk about the sphincters. There are two such sphincters are there in urinary bladder. One is known as internal sphincter, other is known as external sphincters. They are basically transform variety from this particular muscles itself. So this particular thing is important to us. So we start with this particular region of the urinary bladder, and this particular urinary bladder have got inner mucosa, which is having got two layers. That means epithelium, which is urothelium. We understand this transitional epithelium, urothelium. What do we mean by that? And this particular urothelium, deep to that we have the lamina propria. That means this particular lamina propria, which is a connective tissue layer, and this particular mucosal folds, which is present inside to it, have got different thickness based on the status of the bladder. If the bladder is empty, it has more layers of the cells appears, and if it is distended with the urine, that means it has less layer cells which is present because of the distension, just like ureter as we talked about. Then we have the muscle layer. The muscles in this urinary bladder, we give it a special name, we call them as detrusor. So this particular detrusor muscle is present within this urinary bladder, which is, you have to keep in mind this particular word because this is an important question that has been asked in examination. So detrusor is that muscle which is present within this particular urinary bladder, which is present in different layers. Now this particular detrusor muscle may be transformed in some part of the urinary bladder to form the sphincter of the urinary bladder, right? Then we have the serous layer, which is outside layer or external surface of this particular serous layer. Now inside to the bladder cavity, we have a space within this bladder cavity. We call them as trigon of the bladder. This trigon of the bladder, when you're going to talk about the gross anatomy of the urinary bladder, that will surface again about the trigon of the urinary bladder. You have to know what do you mean by trigon of the urinary bladder, what is the landmarks or boundaries of the trigon of the urinary bladder, what is the developmental source of the trigon of the urinary bladder. That also comes in a way. So this particular trigon of the bladder, which is an important region of the urinary bladder, will be coming when you are going to start or when we are going to teach about the gross anatomy of the urinary bladder. So this is how this particular urinary bladder, if you're looking at it, should be looking like. We do not have a slide over here. So we have the lumen over here and this particular outside to it is there. So we have this urothelium epithelium layer which is there. Then we have this lamina propria. Then we have the muscle layer, which you can see that have got layers in different directions. This is 1, this is 2, this is 3. So this particular 3 layers of these particular muscles in there, we call them as detrusor muscle, which is present in this urinary bladder system, which is also a very important landmark you have to keep in mind as an important landmark identification. So this particular detrusor and then fitted with this particular most outside layer, which call them as adventitia, which is outside layer. So this is the whole summary of the urinary bladder. So this is how it should be looking like whenever you are looking into the urinary bladder as a microanatomy is concerned. So this is a real picture. This is how we are seeing here. This is lumen side of the urinary bladder. This is the muscular side. So from inside to outside, this is layer which is seeing over here is kind of like cells, which is transitional epithelium. This particular transitional epithelium, you see that folds are there. They seem similar folds, we see them already seen in case of this particular ureter as well. So this particular folds, as because of this is in stage, we call them as relaxed stage of the bladder. When this particular bladder is distended, the folds obliterates and this particular layers becomes multi-layered to the 2 layer over 1 layer. Then we have the lamina propria, then begins with the muscle layer. This is a layers which you are seeing here, the muscle layer or smooth muscle. These smooth muscles have a special name to it. We call them as detrusor muscle layer. So this is what we talk about urinary bladder. Then we have the urethra, which is also have got same layer, same lining is there. Mucosa, which is having most of them is adjacent to bladder is transitional epithelium. As we go down to the urethra, we have the change in mucosa. We call them a pseudo-stratified columnar layer. We do not have to read about the urethra because I'm just like pitching it, because this transitional epithelium is present to adjacent part of the urethra, or the part of the urethra we call them as, which is known as bulbar urethra, which is present in case of the membranous and bulbar urethra, where we see the part of this particular urethra which is lined by this transitional epithelium as well. So moving back to this, where we have started about bladder, have got three layers: mucosa and this muscle coat and this particular adventitia. This mucosa have got cells which is known as transitional epithelium. We understand what do you mean by transitional epithelium. And then we have this particular lamina propria, which is folded because of the empty state or distended state, depending on it. Then muscle coat, we call them a special name, detrusor is the name. You have to keep this word in mind. May have three different layers: longitudinal, outer and inner, and in between the oblique coat, which may be present in this middle coat, and outside is a serous layer. And this particular serous layer, which is lining with the peritoneum, which is present in some part of it. Now, inner side of the urinary bladder, we have a region, we call them as trigon of the urinary bladder. So, when we are going to study this bladder, you put emphasis on studying about trigon of urinary bladder, which is an important short note to be covered during examinations. So, trigon of the bladder, you have to study separately along with this particular bladder histology. So, coming back to this particular slide where we have started here, we have this particular slides which is present over this region. So, once you see that, it's a very remarkable slide. Once you see that, you will remember that. This is a kind of very popular slide to be given in an examination, because this is one of the slides which can be easily identifiable. So, this is having a star shaped lumen, very well seen, which has a lining cells which is known as urothelium. You can see the multi-layer. This side, which is the window side slide, which is a very clear and more prominently seen compared to this outer side slides. And you can see the layers of the muscle thickness. So, emphasize and look into this transitional epithelium and look into the thickness of the muscles which is this particular tube has. So, muscle thickness is quite large, and next time we will introduce another similar kind of tube slide. We call them as uterine tube or fallopian tube. We will compare it with the muscle thickness there and as well as the cells there. So, this urothelium is quite thick and the muscle is also very thick. The thick muscle is required to have increased or very strong peristalsis, which may be present in these particular regions.